Welcome. Sorry for all the technical difficulties. It is my pleasure, though, to introduce our speakers today for our first of our 2023 summer series on equity, diversity, and inclusion. I am filling the very large shoes of Dr. Soto, and it's really an honor to be able to introduce our two speakers today. I'd like to start by acknowledging and honoring the Miami, Delaware, Potawatomi, and Shawnee people on whose ancestral homelands and resources Indiana University was built. We also acknowledge the displacement of a vibrant Black community in Indianapolis, where the School of Medicine and IUPUI is currently located. I guess I can't really say IUPUI anymore. But I am delighted to have the opportunity to introduce our two speakers, Dr. Francesca Duncan and Dr. David Sturkin. As probably most of you know, Dr. Duncan is an assistant professor of clinical medicine within our pulmonary and critical care division. She received her MD from Meharry Medical College and then did a combined med-peds residency at The Ohio State University. We were lucky to have her come to IU to do her pulmonary and critical care fellowship, and then even luckier to have her stay on as faculty. She is currently also the co-chair of the Equity and Inclusion Committee for the Department of Medicine. Dr. Sturkin is a faculty member in the Division of Hospital Medicine within the Department of Medicine at the University of Wisconsin in Madison. He completed his medical degree at the University of Pennsylvania and then went down to Duke University to complete his residency in internal medicine. He subsequently flew out to the West Coast and did an academic medicine hospital program at the University of California, San Francisco. Today, the topic is the impact of skin pigmentation on pulse oximetry. That's when a hematologist tries to talk about pulmonary things. So welcome, and I turn it over to our speakers.
Thank you so much for that introduction. Dr. Sturkin and I are really excited to be sharing with you all today. How we have decided to kind of break this up is I'm going to kind of take the first half. So I'm going to be sharing my presentation or my talk here. I'll take the first half. Dr. Sturkin's going to follow up after that, and we will open it up for questions and answers at the end. Please feel free to put your questions in the chat as well. We will have someone kind of monitoring the chat for those questions and reading those aloud at the end. All right, so I'm going to share my screen here. All right. I think you should see the correct view at this point. Can I get a thumbs up if that's the case?
Yep.
Okay. All right, great. All right, so as mentioned, the title of our talk today is the impact of skin pigmentation on pulse oximetry. And I have no financial disclosures, but I do, however, have some personal disclosures or biases that I would like to share with you today. And so I recognize that as a Black woman of color, that we're going to be talking about skin pigmentation, and it's obvious that my skin pigmentation is darker than that of white individuals. And so I'm bringing that up because that's some of the context that we will be discussing today. I'm also a native of Fort Valley, Georgia, which I'm sure no one on this call knows where that is, but it's about an hour and a half south of Atlanta, Georgia. Nothing like the big city. And this picture in the center represents me, Dr. Fancy, as I'm affectionately called. And this is me at age 1 for my first Christmas. And the bottom two pictures here represent me as well. I am a proud 3-time graduate of historically Black colleges and universities, as Dr. Mehta introduced. And the top left picture here is me as a second-year Palm Creek Fellow here at IU, and I would argue it were some of the roughest times for myself being here as a fellow in the pandemic, away from all of my family in Georgia. But this is me here at the bottom left, brighter times, as I'm approaching the end of my second year now here as faculty. So what this talk will not be about, we're not going to be talking about racial bias in pulse oximetry. And I'm saying this in quotation marks because racial bias is quite different from skin pigmentation. And the reason for this is because race encompasses so much more than skin pigmentation or skin colors. And mislabeling terms, while maybe provocative, it can mask the underlying issue, and that's just simply not cool. And an instrument is an object and therefore cannot be quote unquote racist. But if diversity is not included in its design, there lies the problem. And so that's what we'll be discussing today. So let's start with some definitions I think that we can all agree on. So the National Cancer Institute defines race as a concept used to describe a group of people who share not only physical characteristics, such as skin color and facial features, but they may also share similar social or cultural identities and ancestral backgrounds. And so that's why I said it's more than just quote unquote race when we talk about this particular issue. And bias is prejudice in favor of or against one thing, person, or a group compared with another group, usually in a way considered to be unfair. And implicit bias, which I think many of us will find from our talk today, may lie in the pulse oximeter, but this is a form of bias that occurs automatically and unintentionally that nevertheless affects judgments, decisions, and behaviors, and in some contexts can affect our patients, leading to worse clinical outcomes. And I would talk about some of that today. So before we begin talking about the pulse oximeter, I would like to provide you with a little bit of some other examples of implicit bias in technology, some that I think all of us are very familiar with. And I like to start with what I like to call the saga of the automatic soap dispenser. So this is not a direct illustration of me here, but I have been one who has experienced this, where you enter into the restrooms either at work or at the airport, and you just put your hand under for the soap and find that it just simply doesn't work for you, and you become frustrated and just have to use your hand sanitizer instead. But the reason for this implicit bias is that there's an invisible light that is reflected from one's skin, which triggers the sensor. And once that trigger is censored, the soap is dispensed. And so darker skin tones absorb more light, meaning there's less light reflected back to the device, which is supposed to censor and activate the soap dispenser. And this is why soap dispensers may not work effectively for people of darker skin tones. Now, the company that created the automatic soap dispenser, Technical Concepts, unintentionally made a discriminatory soap dispenser because many would argue that no one at the company thought to test the product on dark-skinned individuals. Now, while this example may not really be harmful, but just frustrating, I'd like to share another example with you. So I think this actually is one of the quotes that I found from one individual who is, in fact, an engineer, a Black engineer, and he said that the less diversity there is in a workplace environment, the more likely major design flaws will present that only affect people of color. So on to the second example, and so I think many of us are very familiar with this, so I like to call this the saga of the wrong face at the wrong time. And I can say that this has happened to me. I'm sure it's happened to each and every one of you. You're trying to get into your iPhone and your Face ID is just not working. And more often than not, you have to swipe up and put your code in. And the reason for this is because of very similar to the prior example, that there's an issue with face recognition, specifically for people of color. And so this is a quote I found online that I'm a Black woman. I've even been locked out of my Surface because Windows Hello couldn't detect my face. And facial recognition software is being introduced into medical policy and even how we as providers access the EMR. And so I know even here with the use of Epic on our iPhones, you have to be able to use facial recognition technology to be able to actually open up your app. And many times for myself as well, as I'm sure you have as well, I'm unable to log in that way and have to spend the time typing in my code because the Face ID doesn't work for me all the time in all places with various lighting. And so in fact, facial recognition systems are more likely either to misidentify or fail to identify African Americans than any other racial groups. Now, while these two examples are not really harmful, let's talk about the reason that we are here today, and that is the pulse oximeter. So the pulse oximeter was invented in 1974 by two Japanese bioengineers from a Japanese medical electronic equipment manufacturer. And actually, in the COVID-19 pandemic, so in 2020, one of the bioengineers actually died during the pandemic. And there was an article that was published and written about him, essentially talking about the brilliance he had in terms of developing this useful technology years prior. So the reason that this is very important for us, specifically as physicians, is that this is a non-invasive form for us to be able to approximate oxygen saturation levels for our patients. And it uses light absorption to assess hemoglobin configuration as a proxy for blood O2 levels. Now, this is a flawed technology, and the fact that it's flawed, we have actually known about this for 30 plus years. So let's talk about a few terms. So the term hypoxemia means low or inadequate partial pressure of oxygen measured in arterial blood. So this actually requires a blood stick. Hypoxia is rather a condition that causes deficiency in the amount of oxygen reaching the tissues. And the term occult hypoxemia or hidden hypoxemia simply means that when you measure one's arterial oxygen saturation, it's less than 88%, despite reading a normal pulse oximeter oxygen saturation, for example, of greater than 92%. So there is some dyssynchrony in what's observed arterially versus what's observed either on the patient's monitor or on the portable pulse oximeter. And SpO2 is a measurement of how much oxygen your body is carrying as a percentage of the maximum oxygen carrying capacity. So in other words, this is the oxygen saturation detected by the pulse ox. And the SaO2 is the same equation here, essentially, but we're talking about that measurement in arterial blood. So now that we've discussed those terms, let's talk about some clinical implications for the need for reliable measurements of oxygen saturation. And so the first one here was definitely evident during the COVID-19 pandemic, and that was the determination for the need of hospitalization and appropriate triage. So back a couple of years ago during the pandemic, ED providers would use oxygen saturation to determine which patients may need to actually be admitted who had mild symptoms versus those patients whose oxygen was within normal limits and had mild symptoms. And therefore, we felt comfortable in discharging those patients home to just get over the illness at home or to be treated at home. This is also important when it comes to appropriate triage. So when it comes to determining which patients need to be admitted to the general medicine wards versus our step-down units versus our intensive care units, reliable measurements of oxygen saturation is vital. It's also important in terms of the use of supplemental oxygen therapy. So trying to decide whether or not a patient even needs to be initiated on oxygen. And then our various modes of oxygen therapies ranging from nasal cannula to non-invasive BiPAP, CPAP, or even mechanical ventilation in the intensive care unit. It's also important when we're discussing deciding factors for the initiation of specific therapy. So this is another reason that this is important. And some examples of this could be, say, a patient that has PJP pneumonia and they're on appropriate antibiotic therapy, but they are also having issues in terms of having low oxygen saturations. And so we need to know this so that we can then initiate steroids in addition to the antibiotics they're on. Another example would be, say, a patient that comes in with an acute congestive heart failure exacerbation, and now they're coming in volume overload, maybe pulmonary edema on their chest x-ray, and their oxygen saturation is low. Well, this will let us know that we probably need to initiate diuretics, maybe place this patient on CPAP or BiPAP for work of breathing. And so this is another important clinical implication for the use of appropriate oxygen saturation or detection. And lastly, the decision-making regarding fluid management. So if you have patients that maybe were getting tons of blood products post-hemorrhagic shock, and now they're hypoxic, quote unquote, you need to really know whether or not their hypoxia is being accurately measured so that you can know what needs to be the next form of treatment. And then even when it comes to decisions surrounding the need of consultation services. So studies have shown that Black individuals are less likely when they present with STEMI, or even when they present with a heart failure exacerbation. Blacks are less likely to receive cardiac consultation compared to white individuals. And one of those factors that may play a role in terms of when to consult special services is whether or not a patient is in fact hypoxic. And so these are only a few examples that highlight the need for reliable measurements for oxygen saturation. So I'm going to highlight two studies here because I'm a physician scientist and I really want to share with you all what the literature says about occult hypoxemia. And so this particular article shows disparities in hypoxemia detection by pulse oximetry across self-identified racial groups and association with those clinical outcomes. And this was an important study because while most studies have been retrospective in nature, this was an observational cohort study that ended in December of 2020. So it did include some of the pandemic, and it lasted about 2 years. And this was done at 3 academic centers. And you can see here that patients who participated were identified as white, Black, Asian, or American Indian, and they were admitted to the ICU or they had surgery during their inpatient hospitalization. Now, what was paramount about this study is because it was observational in nature, they were able to simultaneously measure one's arterial pulse ox and then also monitor or record what was noted on the pulse oximeter. And the reason this was important because other studies have shown that if there is even a 10-minute discrepancy between collection of the arterial blood gas, comparing that to what's seen on the pulse oximeter, it may not be reliable in terms of deciding whether or not those two numbers can be, compared to one another. So the results of this study showed that Black, Asian, and American Indian patients were more likely to experience any occult or hidden hypoxemia. And remember, that means that you may be hypoxic based on arterial blood gas, but you wouldn't know that because the monitor is actually showing that you are not hypoxic. So these particular groups were more likely to experience hidden hypoxia during hospitalization compared to white patients. And there were no significant differences in occult hypoxemia between Asian and American Indian patients compared to white patients. And the probability of occult hypoxemia increased with lower SpO2 values, which were prominent among racial differences. And so this was, I think, pretty key with this study, because you want to make sure not only are these pulse oximeters accurate, but when patients are truly hypoxic, you want to make sure that they are also able to pick up true hypoxia. And so this figure essentially shows here on the left, going from bottom to top, that as the oxygen saturation observed on the pulse oximeter decreases, you see here that there is an increase in the probability of occult hypoxemia. And so the largest group were the American Indians here at 39.3%, Blacks at 36%, and Asians at 32.8% compared to white individuals of 24.8%. So I think that this was pretty interesting. And in terms of clinical outcomes, they found that occult hypoxemia was associated with increased odds of hospital mortality in surgical and ICU patients compared to normal oxygenation. Now, this was an observational study, so association does not mean causation, but this was an interesting finding for this study. And occult hypoxemia was also associated with fewer hospital-free days in surgical patients, but not for ICU patients. And there was no significant interaction for occult hypoxemia in outcome relationships by race. So the last study I'm going to share with you today is this study entitled Assessment of Racial and Ethnic Differences in Oxygen Supplementation Among Patients Specifically in the ICU. And so this was retrospective in nature, and you can see the 4 groups here: Black, Asian, and Hispanic, and white. And these patients were admitted to the ICU for at least 12 hours before needing any advanced respiratory support, if any at all. And here they were able to measure oxygenation levels and nasal cannula flow rates for up to 5 days from ICU admission or into the time of intubation or non-invasive medical equipment. And the results were interesting. So Black patients had a lower median arterial blood hemoglobin oxygen saturation. So that's the blood draw compared to white individuals. And Black patients had a higher SpO2, so that's what's observed from the pulse oximeter, than white patients. And the same was seen in both the Asian and Hispanic groups compared to white patients. And when controlling for other factors, and so this was really interesting in this study, including use of vasopressors, which we know that if patients are in shock or having hypotension and therefore having decreased blood flow, that can affect pulse oximeter readings. But even when patients controlling for vasopressors, they found that Black race was associated with a higher SpO2 or pulse oximeter reading compared to white race. And so this particular figure just kind of shows this here. So they were also interested in looking at the initiation of oxygen therapy based on race. And so they found that Black patients had a lower oxygen delivery rate, meaning initiation of oxygen for patients, because they presumably were not hypoxic compared to white patients. And Black patients had approximately 0.2 to 0.3 liter per minute lower average oxygen delivery rate compared to white patients. And this was, again, controlling for other vitals, use of vasopressors, etc. So takeaway points from these studies is that despite disparities in hypoxia detection via the use of pulse oximetry, they are still needed in clinical practice because they're non-invasive, and we need to be able to have a way to easily assess oxygen saturations without causing harm or injury to patients. And racial differences in occult hypoxemia are related to variations in skin pigmentation, impacting light absorption and the transmission detection. Occult or hidden hypoxemia has several clinical implications, including triaging, supplemental oxygen use, mortality, and hospital days. And the finding that one's skin or race could actually affect how much oxygen a patient receives should be concerning. And that the lack of inclusion of people of color during the validation process of testing various pulse oximeters and developing reference values is something that should also be concerning, because this underlies the reasons for why these particular equipment pieces are not as effective in people of color. And providers must be aware of limitations with pulse oximeters and variations among brands. And healthcare systems should commit to buying only devices that function across all skin tones, which those are available, forcing other manufacturers who refuse to do this to respond. And I will stop here.
All right, let me get my screen shared. All right, well, thank you, Dr. Duncan, and thank you everybody for having me today. So my name is David Sturkin. I'm a hospitalist from the University of Wisconsin. And unlike Dr. Duncan, I'm not a pulmonologist. I'm not a biomedical engineer or a health policy expert. And really, I didn't have any relevant expertise in this area before I learned about this issue. So I'm going to be coming at this topic from a bit of a different angle. And I'll give you some of my goals here with some learning objectives. So first of all, I want to talk about some of the structural issues behind bias in pulse oximetry, because it's not just a technological issue. And then to give you some examples of ways non-experts such as myself can potentially have a positive impact on issues they find important. And then lastly, I'll tell you a couple of specific ways to get involved in this issue of bias in pulse oximetry in particular. So for me, many of you have probably read this study as well. This was a study in the New England Journal of Medicine from the University of Michigan that was published back in December of 2020. For me, this was the first time I had heard of the issue of bias in pulse oximetry. This was a retrospective cohort study in hospitalized patients that showed that pulse oximetry tended to overestimate the true arterial oxygen saturation in Black patients, but not in white patients. And when I first read this study, my initial thought was, why didn't we know about this sooner? Obviously, pulse oximetry is a technology that's based on light transmission, and clearly skin pigmentation would affect that. So to me, it seems surprising that no one had thought to investigate whether skin pigmentation was affecting these readings. And what I found when I looked into it is that we did know about this. So actually earlier in 2020, in the summer of 2020, Amy Moran-Thomas, who's a anthropology professor at MIT, had published in the Boston Review an article that was describing previous evidence of bias in pulse oximetry. And as Dr. Duncan mentioned, there's a lot of it dating back 30 or more years. Some of the big studies, in 2005, there was a prospective study in healthy volunteers using a few different brands of pulse oximeter that showed bias in pulse oximetry based on skin pigmentation. Then in 2007, the same group of investigators replicated their findings as again. And then really, if you look back, there are studies dating back all the way to the 1980s and quite a few studies. So then once I learned this, my next question was, why hasn't this been fixed? If this is clearly a clinically significant problem, and it's been decades since we've known about it. So at first I was thinking, is there a technological barrier? Is this something that is simply unavoidable with pulse oximetry, that there's no way that we can fix it? And for the sake of time, I can't really go through all the details, but it seems like most experts agree that there actually are ways to fix this problem. And there are a number of proposals for things that we can do to change pulse oximeters to make them more accurate across all groups of people. So then the question is, if this is an issue that we could solve with technology, why haven't we done that yet? And I'm going to propose that at least one of the reasons would be structural racism. But I know that's a provocative statement, and I want to give you some examples of what I mean and talk specifically about the terminology as well. So the first example I have is from Professor Moran-Thomas. She spoke in 2022 at a think tank forum, and she said something that kind of blew me away when I heard it. So this is a direct quote from her. She said, "My first essay was under contract to come out in June of 2020, but was pulled the day before publication after the FDA wrote an email kind of discounting the concerns about racial bias to the New York Times fact checker." So I'm glad that she was able to publish her study in the Boston Review, because actually the University of Michigan study was inspired by her article. So if she hadn't published that article, they might not have conducted that study, and we might not even be talking about this today, because that was really the article that sort of reinvigorated this discussion. So this first example is an example of how, although we presume that the FDA had good intentions with this email, the impact was that they potentially could have buried this issue and made it not come to light. The second example is probably going to come as no surprise, but pulse oximeter manufacturers are pretty reluctant to acknowledge that there are potential inaccuracies in their devices. So this is an op-ed written by Joe Chiani. He's the CEO of Massimo. They manufacture the pulse oximeters that we use at the University of Wisconsin, and also that are used at the University of Michigan. So essentially their pulse oximeters were implicated in the initial study. So they wrote this op-ed in response. And I'll talk a bit about some of their claims later on. And then the last example is an example of how academic medicine can sometimes get in the way of solving issues like this. So this was a letter to the editor that was written in response to the University of Michigan study. I won't read it in full, but there's kind of a lot to unpack here. Basically, this author was pointing out that pulse oximeters, since they are not people and can't think, they can't be biased in the sense of being, or racially biased in the sense of being prejudiced. And then this author goes on to say that we shouldn't be using the term structural racism in healthcare, because he says this will, quote, inevitably further erode the trust of some Black patients and will contribute to, rather than help to remedy, concerns regarding racism in Western medicine. And I think this is a good example because it brings up the terminology. And I would certainly agree that pulse oximeter devices themselves cannot be racist, but the way that they were designed and calibrated and approved can have implications that are different based on race. And so I'm going to talk a little bit about why I would say this is structural racism. But basically, in this response, this author seems to be conflating structural racism with interpersonal racism. So to recap, I gave 3 examples of structural barriers to change. One was that sometimes governmental institutions such as the FDA are reluctant to respond, and you'll see some more examples of that as we go on. Another is that corporations such as device manufacturers might resist acknowledging certain data. And then lastly, academic clinicians and academic publishers can be potentially produce barriers to this as well. But those are all reasons why this is there are structural problems that have gotten in the way of this problem. But why is this structural racism specifically? And there are a couple of reasons, but the first one I think is exemplified by just doing a quick thought experiment. So imagine for a moment, what if pulse oximeters had been shown to be less accurate for white people? So say in the 1980s, if they're shown to be less accurate for white people, or in 2005 and 2007. I can't say for sure, but my guess is that if that were true in 2005 and 2007, it would have gotten more press coverage. And I would think that probably our institutions would have fixed the problem by now. And my impression from looking back is that one of the reasons why this hasn't been fixed is because there has been apathy around the issue. And based on the pattern that other issues have experienced in the United States, the concern would be that this is because oftentimes the United States takes more action on issues that affect white people than affect people of color. And furthermore, I would argue that the only reason why this gained more traction in 2020 was that it came at a time after George Floyd's murder by police, which was a time when the United States was less apathetic about racial bias than they typically are. So we've talked a bit about some of the structural issues, but the question then is, if you're not an expert like me, if you're someone who can't conduct the studies that are necessary, can't engineer better devices, what are some ways that you can help? So there are a few different ways, but the one we're going to talk about today is advocacy. But before we get to that, there are a few caveats that I want to make just to mention before advocating as a healthcare worker. So first of all, you should always check with your division or department to get their guidance. They can give you some guidance on specific rules to follow and potentially give you resources as well. In general, though, at most institutions, they would expect you to do advocacy on your own time. So that means not during a shift, do it with your own resources. So not using your institutional email, not using institutional laptops, things like that. And if you are making any statements, you should clarify that you are only representing yourself and not your employer, unless they tell you otherwise. But like I said, they can often have many resources that can be very helpful. So many institutions have designated governmental affairs officers, or also contract with lobbying firms, and they can help you get connected with politicians or other people who can make changes and things. So for me, when I wanted to try to advocate on this issue, first I needed to gather more information, because like I said, I hadn't really heard about this issue before. So I discovered that we use Masimo pulse oximeters here at the University of Wisconsin. And as I mentioned, those were the brand of devices implicated in the University of Michigan study. So my initial thought was, if there are unbiased or less biased devices, institutions could choose to purchase these instead of the biased devices, which would both improve patient care and then also pressure manufacturers to improve their devices, because there'd be a monetary incentive. So I wanted to know more data from Masimo specifically to figure out if Masimo was a brand to stick with, or if we should switch to something else. So I actually spoke with, I was able to set up a meeting with their executive vice president and their chief operating officer back in February of 2021. And we talked about a bunch of different things, but most of it was kind of summed up in this study that they published back in November of 2022. So the quickest way to summarize their study is with this figure. On the left, we have box plots showing pulse oximetry readings versus arterial oxygen saturation from the University of Michigan study in 2020. And on the right, we have the same, but from Masimo's internal data. So on the left, so the blue boxes are white patients and the red boxes are Black patients. And on the left, you can see that those box plots don't line up. On the right, on the other hand, those box plots line up very well, and they're also smaller, and their error bars are smaller. So basically, Masimo said that this was evidence that from their own internal data, their pulse oximeters did not exhibit racial bias. The problem with this, as Massimo acknowledged themselves, was that these laboratory results were obtained in well-controlled experimental conditions in healthy volunteers, not reflecting actual clinical outcomes or clinical conditions in patients. And if when I was talking to them, it sounded like they had many issues with the previous retrospective study that had been done. As Dr. Duncan mentioned, if the pulse oximetry reading and the ABG are done even a few minutes apart, that can significantly affect the accuracy of the results. So I think that if we asked them, they would say that they didn't analyze hospitalized data because they were concerned about that. But I do want to point out, anytime a corporation submits to the FDA for approval of a device, there are certain public disclosures. And in their public disclosures, we can see that they had about 7,700 data points from healthy adults. So these are healthy volunteers in their labs. But they actually had about 10 times as much data from hospitalized adults. And they didn't mention this in their study and didn't analyze it. So perhaps that means that they chose not to analyze it because they thought it wouldn't be accurate, or perhaps they did try to analyze it and they also saw racial bias similar to the other retrospective studies and then chose not to publish it. I don't know which one of those is the case, but basically this is to point out that I wouldn't necessarily take them at their word on this unless we have independent research being done. But the problem is, so when I concluded this meeting with them and looking into other devices, I couldn't really find very obvious evidence that there was another device that was clearly superior. It seemed like many of the devices, even going back to these 2005 and 2007 studies, Massimo was one of the brands that was using that, which did show racial bias, which again conflicts with their internal results. But there are also two other brands that were also racially biased, and these were some of the most advanced brands that are available. But the problem is, so as I mentioned, I couldn't find any other alternatives to convince my institution to buy instead of Massimo, and I wasn't even sure if there were better alternatives. I also can't make Massimo perform additional analyses on their data, and I certainly can't make them change their devices. But the FDA can do those things. And really, we need someone impartial and independent to be evaluating some of these claims. So next, I turn my attention to the current FDA requirements, which I think are part of the problem here. So there's actually a lot to talk about with this, but for the sake of time, there's just kind of one sentence that I'm going to focus on. So in the FDA requirements, they say your study should have subjects with a range of skin pigmentations, including at least 2 darkly pigmented subjects or 15% of your subject pool, whichever is larger. So there are a few problems with this. One, they only require 10 total subjects in the approval process for a device that's going to be used on literally millions of patients. But also the problem here is that they don't require any sort of subgroup analyses to ensure accuracy in all populations. And if you think about that, if you have a device that is, let's say, very accurate for the 85% of subjects that have light skin, but is very inaccurate for the 15% of subjects who have dark skin, the device itself could still pass because we're just looking at the aggregate data. And worse than that, that could actually create a perverse incentive for manufacturers to actually try to optimize their devices specifically for light-skinned individuals, because even if that makes the accuracy worse for individuals with dark skin, it still would make their device look better overall. And like I said, there are many other sort of issues with the FDA requirements, but just for the sake of time, we're going to focus on this one. But most of what I've talked about here has happened in 2020 or early 2021. You may be wondering what's happened since 2020. So in January of 2021, after the initial New England Journal of Medicine study, a group of senators sent a letter to the FDA asking them for more information and urging them to address the issue. The FDA never actually directly responded to them, but they did put out a news brief where they warned in general about some of the limitations of accuracy of pulse oximeters, and they mentioned skin pigmentation as one of them. And then really not a whole lot happened publicly, but behind the scenes, a lot of research was being done, some of which Dr. Duncan already talked about. So for one thing, we found 3 more retrospective studies in real patients that corroborated the findings of the initial retrospective study. And I think very importantly, they specifically all showed overestimation of the arterial oxygen saturation. Some of the manufacturers' claims were that, one, this was a unavoidable signal to noise issue, but that would cause random error, not systematic error. And so that would not have directionality to it, and certainly would not have consistent directionality. And then furthermore, if there was an issue with these retrospective studies where simply the timing of the ABG versus the pulse oximetry reading was the issue, that also would be expected to cause random error. So the fact that all of these studies showed error in the same direction really points to a systematic issue, not just random error. But this was 3 different studies in different types of patients that all showed kind of the same thing. Then we also had studies that Dr. Duncan mentioned that showed that the bias is not just a sort of incidental finding, it is actually associated with higher rates of organ failure and death as well. In response to this, back in April of 2022, the FDA put out a news release, essentially hinting at the idea that they might need to change their approval requirements. Then in August of last year, a larger group of senators sent another letter to the FDA. In September, the FDA put out a longer safety communication, again, kind of hinting at the idea that they might need to change their requirements. And then the big event was back in November of 2022, the FDA convened a meeting of their Medical Devices Advisory Committee. And this URL at the bottom of the page is a link where you can watch the whole meeting. You can't actually search it on YouTube because it's unlisted, but this link does work. And the nice thing about this meeting from an advocacy standpoint is that this is a public meeting and they accept written comments and oral comments. So I ended up submitting both of those. And I actually submitted those, you can find those here. This is the URL for the written comments. I actually submitted those with Dr. Ariba Kara, who's a hospitalist at IU. So we co-wrote this letter to the FDA through a group called Home Run. Home Run is short for the Hospital Medicine Reengineering Network. It's a group of about 70 different hospital medicine divisions that have collaborated on a number of different academic projects, especially during COVID. And through this group, we were able to get this signed by about 157 medical professionals from 34 different institutions. And then to my surprise, actually, the Society of Hospital Medicine and my own institution both used our letter as a basis for their own submissions to the FDA. Again, for the sake of time, I don't have time to go through everything in detail here, but these are the basic recommendations we gave, which are all kind of low-hanging fruit, essentially, that you don't have to be a technical expert to be able to recommend. And if you do go to that URL that I showed on the previous page, you can find the full recommendations along with citations and explanations, but I'd also be happy to answer questions. So in brief, some takeaways from the meeting. Again, I have a URL here with a longer description of some of my takeaways from the meeting. But for one thing, Massimo actually submitted its own letter supporting more regulations, which I thought was great. They mentioned things like wanting approval studies to include equal proportions of patients who have light skin and dark skin, and also some requests for intensifying approval requirements. Again, being cynical, I would guess that the reason why they asked for these regulations is that they think that their devices would pass that bar and that some of their competitors' devices would not. So this would give them a competitive advantage. But that being said, if their devices are better, then that's a competitive advantage that I think they should have. So I think it's still a step in the right direction. And then in general, the panel agreed with the recommendations that we gave through Home Run. And they also submitted a number of great recommendations to the FDA. So all good news. But unfortunately, this panel was only an advisory committee to the FDA. So nothing that they said or did had any sort of binding nature on the FDA. So I emailed the FDA a couple of weeks ago just to see if they had made any changes yet. I got a kind of boilerplate email in response, basically saying that they're taking this very seriously, but they haven't taken any actions yet. Or specifically have not changed their requirements. They said that if they have any updates, they'll put them on this webpage that I've listed below in case you wanted to keep checking that. But they're not doing nothing. So the big thing that they're doing right now is they've sponsored 2 different studies. One of them is a prospective cohort of hospitalized adults being done at UCSF, and the other is a prospective cohort of hospitalized children being done at Stanford. And this will be great because with these being prospective and in hospitalized patients, we both can get prospective measurements that have simultaneous readings, but then also this is in real hospitalized patients and not healthy volunteers. But then you might be asking, are we just waiting for the FDA to act? Is there anything that we can be doing right now? And there are 2 things I want to tell you about. So one, there's a group called Open Oximetry. You can find them at openoximetry.org. They are a research collaborative that is led by the UCSF group that did both the 2005 and 2007 studies that I'd mentioned before, which also are leading the FDA-sponsored study in adults. And they do a number of really interesting things. So one, in the center of the screen, you can see that you can search different devices. So they're actually independently validating a lot of different pulse oximeters. And their plan is to list accuracy data, including broken down into subgroups. They don't have a lot of devices there yet, but it is kind of interesting to look at if you want to think about what devices to purchase. You'll find that actually many devices are not as accurate as they've told the FDA. So having independent analyses of their accuracy is very helpful. Also at the bottom right of the screen, you can see a Join Now button. That allows you to join their collaborators forum. It's kind of like a mailing list. They'll ask you a bit about, what you want to accomplish by helping out with the collaborative, ask you if you have any specific expertise. And then also they'll notify you of any meetings or things like that. And it's been useful being part of their mailing list. They've notified me of a few meetings and sent me some documents that have been helpful in learning about this. So I'd encourage you all to check that out. But the second thing is there's actually going to be another relevant FDA meeting in September of this year. So this one is broader. It's basically just, the title is Advancing Health Equity in Medical Devices. They haven't given a lot of information yet about exactly what they're going to be talking about, but I think this will be very helpful and something that it'll be useful to have the FDA address. And I also think this is something that there are opportunities to do it correctly, and there are opportunities to potentially do things incorrectly. Not enough time to go into all of this, but there are issues with say like race correction in a lot of clinical calculators, and there are issues with certain areas of medicine where using subgroups has turned into different equations that has potentially worsened disparities in health. So I think this is not a very simple answer about exactly what should be done. But they, again, are also accepting written submissions and oral submissions. You can find the email on the screen here is where you can email if you want to submit anything. The deadlines are August 2nd for oral presentations and August 10th for written presentations. And if you want some background information, I found this particular article very helpful by Dr. Fox Rawlings. They basically talk about some of the legal basis for the regulations that the FDA has put into action, and specifically some of the issues that they've had with diversity in clinical trials and what their requirements maybe fall short on. But I want to end just with a couple of lessons that I learned about advocacy through this. So one, I think the most important thing is really to learn as much as you can about the topic and its context. Like I mentioned, I was not an expert at this to begin with, and I'm still not an expert in much of the content. But it was very helpful for me to read as many articles as I could, try to figure out the regulatory environments and get a sense of what actions were being taken. Always discuss with your institution just to make sure you don't violate any rules. See if you can find out any sort of advocacy work that's already occurring so that you can join with that. That's usually more effective than trying to reinvent the wheel and start something from scratch. And then seek out other professional societies or other groups of people who might partner with you. So if you do write a letter or something along those lines, you can get people to sign along. Then look for a venue for advocacy. So oftentimes government meetings are great for this because they are open to the public, especially for different issues. Local governmental meetings are very effective because since they're smaller, especially if you're a healthcare worker, you can really have a lot of impact on that. And then lastly, think about what leverage you have that can be used to promote change. So things like the purchasing power of your institution, or some of the laws that regulatory bodies are supposed to be following, or things like that. But with that, I'd be happy to answer any questions. If anyone has any thoughts later on or would like copies of slides, feel free to email me at sturken@wisc.edu. And briefly, just some references there, just so they're on the recording.
Wonderful. For those with questions, please throw them into the question and answer box. We already have two, I guess, one question and one request. I think folks would love to have those sites in the chat, but I guess if there's some way that we could, have those, the YouTube site and some of the other places that we could distribute to the folks that joined the the meeting today, that would be wonderful. The one question is going back to the FDA requirement for having 2 participants or 15% of them having dark pigmentation. Isn't that significantly less than the percentage of our population that are people of color? Would that be further evidence of systemic racism?
Yeah, so I looked into that because they didn't explain why they chose that number. It looked like it was similar to the proportion of Black people in the United States. I think I saw like 13 point something percent, but doesn't include other people of color, obviously. And this sort of gets a little bit to one big technological issue is how you measure skin pigmentation. There are some scales that are pretty problematic, basically, and a lot of them are very subjective. And so just the definition, they just say dark pigmentation, but don't define that at all. That's actually one of the big things that came up in the FDA meeting. So I think that it was meant to be sort of a quota meant to approximate census data, but really did not achieve, I don't think achieves kind of their goal. And also I can certainly, I'll email out my slides to the organizers. I had a lot of URLs in there that weren't on the slides. So anyone's welcome to those.
Next question, are there any grant regulations that require researchers to include patients of color in device development? I reached out to the group that formed the in-ear pulse ox, reads via tympanic membrane. They are funded by NIH, but did not include any patients of color in the study thus far.
Yeah, I think, Priscilla, thanks for that question. I think as far as I know, there is not a requirement to have a certain number of people of color in studies per se, but the idea is that we need to ensure that we're including a diverse group of patients in studies, especially when we're trying to make sure that whatever we are developing or testing is applicable to all people.
Yeah, let me see. Actually, I think I have a slide on this. Let me see if I can pull it up real quick. I had some extra slides that I didn't have time for. Let's see. Yeah, so there are no formal requirements or binding requirements. There was a law in 2012, the FDA SIA, which encouraged multiple agencies to ensure that medical products be analyzed for safety and effectiveness in key demographic groups. But it really just says encouraged. And so the study that I mentioned at the very end, the 2018 study by Dr. Fox Rawlings, they performed an analysis where they looked at the 22 supposedly called high-risk devices that had been approved since this law had been put into action. And they found that only 14% of those devices actually provided sufficient subgroup analyses for gender, race, and age. And they mentioned a lot of good recommendations for how this should be changed. First of all, making it a binding requirement. And then interestingly, the FDA put out an action plan, which again was kind of them just saying what their goals were. And they said that if it is known that a subgroup is known to have a significantly different response than the rest of the population, or if a specific claim is sought in a certain subgroup, additional analyses may be needed. So this was actually when I talked about leverage before, this was the leverage that I kind of focused on for the FDA, that basically there was a law that encouraged them to require these subgroup analyses. And they had said in their own words that they were going to try to do that. And now that we have this data that shows that in patients with dark skin pigmentation, the devices do work differently. Based on their own words, this is basically what I said in my letter to them. Based on their own words, they have said that they should be requiring subgroup analyses. So this is kind of what I was mentioning about finding leverage. And this is, I think, also something that would be really helpful for people to give opinions on in the September meeting, because I think this will be a lot of what they talk about, because this is more broadly talking about all devices.
If I may ask a question. So faced with this data and the fact that we do have patients of color who come in with probably borderline pulse oximetries, how do we interpret the data so that we're actually providing optimal care? I recognize the fact that they're still safe and relatively easy to use. But understanding that we are not getting accurate data, how do we actually interpret that for our patients?
I mean, I guess I would argue two things. And so that's kind of one of the things that we do with pulmonary function testing as well. We as providers also have to use, since we know that these types of equipment are faulty, we have to kind of use our own clinical judgment. So if we're talking about a situation in which a patient may be right on the borderline in terms of their oxygen saturation based on pulse oximetry, if the patient is inpatient and you're trying to figure out, whether or not you need to triage that patient to a higher level of care, if it's possible, then an ABG or arterial blood gas can be obtained. And since we know that those typically are more accurate, then making our clinical decisions based on that, especially for people of color, is a better scenario. The problem here becomes when we are faced with dealing with this in outpatient situations, because we're not able to get ABGs, for example, in our pulmonary clinics. That's not something that we're able to do. So kind of relying on your own clinical thought, where if the patient is kind of borderline, maybe leaning more towards that they might be in fact hypoxic if they are someone of color. And I think that's maybe something that we're going to have to do until we see some changes being made with the pulse oximeters. I think specifically here at IU, we are in a unique situation where we have IU, and then we also have, or IU Health, and we also have Eskenazi. And so when we looked into this, some of our colleagues in pulmonary, we found that we're using, very similar to Dr. Sturkin, we're using the Masimo pulse oximeter at IUH, but at Eskenazi, it varies all over the place. So we are using different pulse oximeters in our outpatient settings, in our pulmonary clinic settings compared to our primary care settings, and then also in our ICU. So I think we're just kind of trying to work on a better way to make sure that we're using consistent oximeters across the border.
Great. Well, I think at this point we can kind of wrap it up. I want to thank Dr. Duncan and Dr. Sturkin for just sort of a wonderful discussion in letting us know both how we need to interpret some of the data we get, and then probably also importantly, how we can potentially advocate to make the necessary changes. So thank you to both of you, and I hope everybody has a wonderful evening.
Thank you for having us.